Good evening, everybody. Kannan, thank you for the kind words. Rakesh, Sapna, Srinivas, Naveen, all the leadership, thank you for the opportunity to be here and give this first oration. I'm proud of what you all guys do at the Proton Center, and congratulations to all of you all and pushing the frontiers for both research and education. These kind of seminars is wonderful. When Sapna called me and asked me to give this talk, the title sounded very fancy, so at once I said yes. And then I forgot about it, and then 4 or 5 days, we always make our talks at the last minute. I sat down to think what I'm going to say. And I said, such a diverse audience, there's so much happening in oral cancers, what do I say? And very frantically, I texted her and I asked her, I'm getting nervous. So she gave me a whole list of like 20 things to speak on. And I said, if I do that, it'll take me more than an hour. Then I said, what do I do? She just said, say a few words that will stimulate the crowd. Some of the youngsters will take to research. Some of the older guys will get into research. And I thought that's what I'm going to do in the next, the time allotted to me. Hopefully, something for everybody. Whether you're a student, you're a young postgraduate, you're a young consultant, you're a senior person, something on research. It's an important topic. Oral cancer is our cancer. Here is the Globocan data. Look at the dark blue spots. It's all centered in our part of the world. Of 377,000 cases, nearly 40% are in our country, about 120. Of all the deaths, 175,000, about 72,000 in our country. In any given head and neck unit, 50% of our operative work is head and neck cancers. It's also a topic dear to me. In years that I worked, I researched maximally on oral cancers because it was our cancer. And you can see a collage of what we did as a team. Some of them were put up by the previous speakers in panels and other things to drive a point home, try to make an impact on the global research on oral cancers. It's not only us. I did this kind of a mesh search on publications here in head and neck cancers from the time I started my career in head and neck till very recently. And you can see that the output from our country, and it's not only Tata's, is increasing. Year by year, the amount of research coming out, the amount of contribution coming out into world literature is increasing from our country on head and neck. But look at this very specifically on oral cancers. A recent publication this year mapping the landscape of research from across the world in oral cancers. As you can see, as a country, we don't do too bad. Maybe this pointer works. We don't do too bad. The total number of publications, fairly high. Total number of citations, fairly high. Citations to the amount of publications, the H score and the H core score, which tell you the value of these publications. Fast forward to the 10 top publications globally, and you can see 2 of them are from our country in oral cancer. Number 4 is our neck dissection publications. When this was published, we had about 600 citations, which has now gone to 1,200. And Dr. Shankar Narayan's study, which again was cited in the top 10, and that's on screening, and I'll briefly refer to it as we go along. But there's still a lot to do. When you look at mortality to incidence ratio in our country, if you're diagnosed with a cancer in the West, out of every 3, Diagnosed, one succumbs. But in our country, the mortality to incidence ratio is about 0.7. That means for every 3 diagnosed, we lose 2 patients. So though we are publishing, we need, it's multifactorial, there's socio-economic, late presentation, but still we lose more patients than the developed world. And the numbers are going to continue to increase. So we have to do something to help our patients on a war footing. Here's Globocan projection to show you that the number of oral cancers are going to increase by 2040, more or less double. Now, when we say cancer research, everybody has fancy connotations in their head as what is research. Here's a cartoon of the cell showing the intracellular signaling network of pathways. And people think this is all about research. You have to do that. But research basically is 4 types. Basic research, where you do this kind of stuff. Translational, where you do a little bit of clinical tied up to basic research. Pure clinical research, which are trials like the ones we do, and epidemiological research. So what's the roadmap that I need to give? What's the ideas that I need to give in the next decade if we have to make an international impact plus help our patients? Which type of research do we do? If I had to put my money on something, it would be basic research. Because the problem is that if you don't know how something works, then you don't have a roadmap on what to address and make it better. So basic research is the fundamental of the kind of research we do. Look at the success stories, Glivec and CML, promyelocytic leukemia and retinoids. These were hopeless diseases. You now have them, promyelocytic, 90% cure rates. Lung cancer, when I was young, they never lived more than 6 to 9 months if you didn't operate them. Today we are pushing out to 3.5 and 5 years. Very good targets that we have. And precision oncology is a whole new, science. We are now targeting actionable mutations. So basic is good, but basic takes a lot of time. I'm just going to go quickly through this Glivec story and CML. The Philadelphia chromosome was found in 1960. And then look what happens in 1973. 13 years later, they showed it was chromosome 22 and 9. Then in 1980, they showed a translocation. And so on and so forth. And then in 1993, after they found the tyrosine kinase, they believed we had an actionable mutation that we could target with Glivec. Diagnosis started in 1960. The success story came in 1993. So it takes a lot of time if you have to do this basic research. What would be, we know in head and neck that we have the tumor progression model for more than 3 decades. Basic research. We knew that we don't have any actionable mutations. You've seen presentations earlier, there's PDL1, beta tubulin, loss of heterozygosity, EGFR, but they aren't as strong as in other parts of the body, maybe brain, lung, hematolymphoid malignancies. So we have to do basic research in head and neck, but it's not the roadmap that I would say the rank and file of our country needs to do over the next decade. We need something which is more tangible, low-lying fruit where we can show benefit and impact. So if we want to do research in the country, we've got our Honorable Prime Minister saying make in India, but for me, you make in India and we have to now transition from a phase of international recognition to international leadership. So I loved the previous discussions where we do metronomic chemotherapy, which is nice, cheap, good response. Manish, who is a very popular medical oncologist, said that he would probably want to give it in the neoadjuvant setting. It's good. We all use it because of affordability, but it's not part of any guidelines internationally. So whenever you think of research, and that's the advice I can give you in the roadmap for the next decade, it should be something that will impact internationally as well as help our patients. So what is the advice I would give for the roadmap? I've broken it up into 4 different categories. Early detection, generating data with a global impact that will save lives, innovative approaches that we can improve the quality of life of our patients plus outcomes, and lastly, cost-effective strategies. The world needs cost-effective strategies, and access to healthcare is a problem even in the developed world. So let's look at early detection quickly. We see patients like this. It's a paradox. Oral cavity is easily accessible. You don't need fancy tests. You just need someone to peep into the mouth, and you need a good light. Even if you don't have a torch light, you're blessed with enough sunlight in this country. Yet we see patients like this. 9% of our patients are in early stage. There's a lot we can do for early diagnosis. Salivanomics, looking at proteins, mRNAs, microRNAs, metabolic compounds, diagnostic aids, digital technology, biomarkers. Now we are even giving immunotherapy to reverse pre-malignant conditions. So what's the roadmap for the next decade for us so that we can get our cancers early? Look what happens when you look at diagnostic aids. All randomized evidence going for more than 2 decades. Bottom line, we've done a lot of this when I was at Tata's, Raman spectroscopy, autofluorescence. Bottom line, none of these are useful. Look at salivary biomarkers, whether you use genomics, epigenomics, proteomics, transcriptomes. Now we've started going into multiplex panels. Look at the third bullet. It's promising but not standard of care. So I wouldn't advise you to spend all your energy unless you're very close in that niche area to do that kind of research. So what's the research that we can do for early diagnosis? Dr. Shankar Narayan's study, done in the southern state of Kerala, randomized 2 populations, about 100,000 patients in each arm. One got health education with visual examinations. Social workers peeped into the mouth of people once every 3 years. And the other only got health education about the harmful effects of tobacco. Did not demonstrate overall benefit. But in those that took tobacco and alcohol, they seem to be a benefit. Now look at a rehash of the same data published just a couple of years in JCO. The first publication came in 2005, one of the top 10 data re-looked at. Now if you start looking at an entire population, you need to screen 2,000 people to save 1 death. But if you look at people who smoke, drink, 1,000, half the number will be screened. So it becomes less costly, less labor intensive. And if you look at people who are at the highest risk, who consume a lot of tobacco and alcohol, you just need to screen 600. There comes the concept and what we should research in this country, or my advice for the next decade, is to do risk-based screening. I reviewed the literature, wrote a nice editorial in Nature, and showed the benefit that in resource-constrained countries such as ours, high-risk screening is what we should do. And here we have to export our ideas to the West. I said you have to make an impact internationally. even if you, in high income countries, high risk individuals, in cancers that are not so common, and even among cancers that are common, risk-based screening is what we should research on in oral cancer and then send the model out. So everybody doesn't need to get screened for colorectal. Everybody doesn't have to get screened for breast. You have at least 10 randomized trials in breast and very, very divided opinions. So on the first, we should do risk-based screening, generating evidence and saving people's lives. And this is work that we did. It took us 10 years, but it found pride of place, and I showed you it's in the top 10 all-time oral cancers. Very simple question. Should you operate the neck? Narayan asked whether you'll do sentinel node biopsy. Patient comes with a small T1, T2 tongue cancer. You can excise it per orally. Should you do the neck? Two schools of thought. One school, wait and watch. One school, do the elective neck dissection. And both had their own advantages. So very elegantly we showed in this trial of 1,281 patients that we screened, analyzed 500. If you did the neck dissection, you save lives. For every 8 neck dissections you do, 1 life is saved. And for every 25 you do, 1 disease-free control. That's, they don't relapse in the neck. So you're saving lives doing the neck. So here's data that is generated from this country that now has pride of place in the New England Journal of Medicine. I'm not saying it to brag or show off what's done, but just to show you the impact. It's the first surgical trial globally, head and neck, in the New England Journal of Medicine. It's the first surgical trial that came in ASCO as a plenary, and it didn't cost us much. That's all it took to cost. Everybody thinks that you need a lot of money to do trials. About 20 lakh rupees. We just need 1 dedicated trial coordinator, 1 fellow. Patients were there. It was a low-cost trial. So again, stimulating y'all, choose a question wisely. And you can answer it, and you can have pride of place in these. Look at New England Journal of Medicine. They have simple trials. They've got things like ivermectin for head pediculosis, published in New England, a common problem, but with definite results. So you must focus, and if we have to make an impact, on low-cost, impactful research that can save lives. And here I'm leaving you all with ideas which you all can do in the next decade. Look at this. It came out in the panel. Will you radiate, not radiate? Kannan was saying, I won't radiate. Someone was saying, I'll radiate. Because we don't have level 1 evidence. Single node positive, would you radiate? Multiple nodes, would you give CT-RT with no ECS? Close margins, would you radiate? PNI, LVI, depth of invasion, again that came up in the panel. We can research on that and know when to give adjuvant. And of course, if I don't put this last point, Sapna is not going to give me dinner tonight, whether protons are better than photons. And she's made a strong case today that we have to generate data for oral cavity. And I totally endorse what you said. We have to have the data and convince the world, yes, that's the way that we need to go. And here is one such effort from our country. It's a multicentric trial called the ARREST trial, looking at depth of invasion as the only factor to decide whether we need adjuvant therapy or not. They've gone through nearly 2/3 of their recruitment, and very soon we should have another high impact article from our country. Innovative approaches, improve outcomes, quality of life. That's my third advice for the roadmap for the next decade. Chemotherapy. Oral cancer is a surgical disease, But it started when I was at Tata's. Our group very elegantly showed there is a role of giving neoadjuvant in borderline resectable lesions. And then this study was shown real world. The data is continued with more than 3,000 patients. These are in borderline resectable patients. But we could do it to improve survival. People say it's not useful, but here are the 3 randomized trials. They don't show benefit in overall survival, because if you look at the number of patients in all 3 trials, they're 200, 250. All of us who know statistics know that if you have to show a 5% difference in survival, you need at least 500 patients. Look at the last column. There was a benefit of giving chemotherapy. Improve in overall survival in patients who respond. So maybe we can do a trial, impact on outcomes, incorporating neoadjuvant chemotherapy. 20 years back, no one thought chemotherapy would come in larynx and hypopharynx. We used to operate all. And then someone did the VA trial, and then the whole paradigm has changed. So maybe we can do that kind of research, challenge dogma. That is the advice that we need to do. Or be innovative. We see a lot of patients like this, need to resect the mandible, the bone is not eroded, neoadjuvant chemotherapy given. Look at the great response. It's become a small dimple. You can now save the mandible. So here in a cartoon it shows a tumor sitting there. Give your neoadjuvant chemotherapy and it shrinks, and then you can get away with a less. We need to do this kind of research, show the world it's our cancer, improve our patients' quality of life. And we did a phase 2 randomized trial led by one of my colleagues, Dr. Chowkar. We randomized patients, one into the standard segmental mandible, one got neoadjuvant, then surgery, then adjuvant treatment. And we were able to save the mandible in half the patients. And it's now gone to a phase 3. So a simple study again showing us that you can impact on quality of life. And last, cost-effective strategies. Vijay has shown all these cost-effective strategies of metronomic chemotherapy. We need to do it. But with a caveat, Vijay I think is gone. It should be part of international guidelines. You can't use it in this country saying we can't afford costly treatment, so we are giving our patients that. You have to challenge what's done in the West, and even the West would ape this kind of treatment. And many ideas. We can do metronomic, we can do the low-dose immuno, we can use alternatives to cisplatin. Now, can we do it? What are the strengths in our country? I've given you all 4 areas that you all can research in the next decade. We have large numbers. Our study was single investigator study, which very few people do. And every institution in our country has a large number of patients. We have world-class infrastructure in the majority of our institutions. We have a pool of talented professionals, and our overheads are very low to do a trial. In the West, if you wanted to randomize one patient, it got you $20,000. You can do the same year for a couple of hundred rupees or a couple of thousand rupees. So we have the infrastructure to do research. I did a study as to why people don't do research in our country. Basically, it is citing lack of time. Everybody believes that research will change practice. Most of our doctors go into pharma-funded studies. And it's unfortunate that half the respondents were from academic institutions and didn't want to do research. So we have an infrastructure. We need a change in mindset for us to impact. What else we can do to strengthen and increase our outputs? What would be my advice for the next decade? Strengthen our electronic medical records, HIS, Hospital Information System, use big data. We have the Infosys, we have the Wipros, We have Google Cloud now in the country, so you can use all this data capture and you can have better data management and biostatistics from retrospective data, just capturing your data. And that would help us to churn out a good number of papers just because of the sheer numbers. We need to have our reporting in a synaptic form for that. And I'm just showing you studies from the West that changed the way we manage the neck. All retrospective data. The Italians, MD Anderson and the MSKCC, large number of patients. We shifted from the radical neck dissection to the modified radical neck dissection without removing the accessory and the sternocleidomastoid, showing that we had same control and less morbidity. If we had not got this retrospective data and waited for a prospective study, we would have our patients like that, where 50% of our patients would have change in function, 91% of our patients would have some limitation in functions. So it doesn't always have to be prospective. It can be good data capture, and I've shown you an example how the West have done it. And all of y'all in head and neck think, what are the publications from Sloan Kettering and MD Anderson? All retrospective reanalyzed data. Very few prospective studies. We need to form cooperative and collaborative groups. Look at our literature. It's all from EORT, RTOG, the SWOG, the intergroup. Look at the collaborative ICOR, which showed depth of invasion is important, and it changed the staging. It was just 11 institutions that pooled data together. 7 institutions pooled data and changed HPV staging. So we need to collaborate with each other. We can't work in our own silos. Public and private sector both have the infrastructure. AIMS can collaborate with AIMS-like institutions. DAE, that's the Department of Atomic Energy, which is Tata Hospital, can do with their institutions. And we in an organization like Apollo have 19 cancer centers. So there's no business why we should not be collaborating, have one data set, and just look at it retrospectively and answer so many important questions. And then, of course, we have organizations like the National Cancer Grid and the HNCOG that can help support this kind of studies. So we need to collaborate. We need to be in cooperative groups. And here again, I've put up a collage to show you that all the impactful oral cancer and head and neck research comes from collaborative groups. And that's something that we need to do. And I put this slide up just to tell you that it could be done in the private sector. Here is a JCO publication, 23 American College of Radiology institutions, less than 300 participants, looking at the role of PET CT scans in the N0 neck. And these are the findings. Now I'm putting the question to y'all. If 5 of y'all on one table see oral cancers, amongst yourselves, 50 patients you could do in 1 year. We do PET scan for the majority of our patients. I'm sure you would be very proud to have seen your name here on a cancer that you treat, a cancer that you investigate with the PET scan, but never had the thought process to collaborate with your colleagues and do that kind of research. So we need to be mindful of simple things that we do in our practice that can impact on study. And to me, it all needs a change in attitude. And I love to play this game. Some of you all may have seen it before. Have you seen it, Sapna? You have. So for the youngsters in the audience, I've done this before. If each letter in the alphabet was given a score, so A is 1, B is 2, C is 3, and so on and so forth, Z is 26. We all want fame. You add up fame, it comes to 25. We all want money. So when you add M-O-N-E-Y, it comes to 72. Family, 66. Your work adds up to 67. Look at love and sex, how low it scores. But what gives us the perfect 100? And that's a change in attitude. So we've got infrastructure, we've got the questions, we've got the patience. It just needs willingness of us to change. And I gave you the 4 broad headings which I feel we should research on. The pundits will do the basic research. But if you do these 4 areas, we will have an impact. And those are the low-lying fruits where we will impact internationally and also save the lives of our patients. So thank you once again. I know it's late in the evening, but thank you so much to be patient and sit so late. Thank you very much.
Thank you, sir, for this enlightening oration. Not only speaking with you, but whenever you talk, there's so many things to learn for an youngsters like me. Now, I request the chairpersons to join for the felicitation for Dr. Anil D'Cruz, sir. And I request Dr. Alexander John to honor with plaque. Give a big round of applause. I request Dr. Rakesh Jalali, sir, to come onto the stage for a pic, and Dr. Sapna Nangya, Dr. Naveen Hedne, Dr. Sandeep Dwara, and Mr. Harshad, and also all the my colleagues, Dr. Prasad, Dr. Joseph, Dr. Pavitra, Dr. Patrick, Dr. Abhilasha. This is the head and neck CMT unit. Yes, I am the calling. Please come onto the stage for a pic.